welcome to the talk on imaging of idiopathic interstitial pneumonias. These are my disclosures, none of which is relevant to the current presentation. The learning objectives for this talk are first to help you to recognize the CT features of all of the idiopathic interstitial pneumonias with a focus on the more common entities, and finally to recognize the importance of multidisciplinary diagnosis in establishment of a diagnosis of IIP. This is the 2013 ATS-ERS Classification of Idiopathic Interstitial Pneumonia, and I think it's very helpful in several ways. If you look at the left-handed column, it divides the interstitial pneumonias into the chronic fibrosing interstitial pneumonias, smoking-related interstitial pneumonia, acute and subacute interstitial pneumonia, and rare entities. Then we see that there is a morphologic limb to this classification and a clinical radiologic pathologic diagnosis. The important point for us as radiologists and indeed for pathologists is that we are morphologists. We make pattern diagnoses. It remains the task of the clinician to assign the clinical radiologic pathologic diagnosis with appropriate input from clinicians and radiologists and pathologists at a multidisciplinary conference. We will go through each of these entities in turn, and I will describe them, the radiologic features and some of the pathologic features. The final thing I want to point out on this slide is that there are some idiopathic interstitial pneumonias that are unclassifiable, that do not meet criteria for any of these patterns. The next important thing for you to know is that usual interstitial pneumonia, as the name suggests, is the most common interstitial pneumonia, being found in probably about 40% of all IIPs. NSIP and the smoking-related conditions are next common. Organizing pneumonia is relatively rare. Diffuse alveolar damage is uncommon, and LIP is rare. Why is it important for us to make these diagnoses? I think this is the most important chart. It's old now, but several other papers have shown similar findings. And it shows that if you, as the radiologist, makes a diagnosis of UIP, you are telling the patient and their physician that their 5-year survival is going to be somewhere between 40 and 50%. That's worse than the prognosis of breast cancer and not much better than the prognosis of lung cancer. This is a serious diagnosis, and you have the responsibility of making it. Fibrotic NSIP has a somewhat better prognosis than UIP, but still not great in the long term. But the other interstitial pneumonias have a much better prognosis. Also important to be aware of the relative incidence and mortality of these conditions. So IPF happens in 5 to 20 per 100,000 patients. Approximately similar to sarcoidosis, but less prevalent lower incidence than lung cancer. If you look at the mortality per 100,000, the mortality from IPF is approximately 1/10 the mortality from lung cancer. You can see the mortality from sarcoidosis is substantially lower. And this is another important graph. I'm not going to go into any details here except to say that the mortality from pulmonary fibrosis is increasing and continues to increase. Some of this is because people are no longer dying of competing causes and also because of improved diagnosis. So we're going to begin now by discussing the fibrosing interstitial pneumonias. And they are UIP, NSIP, chronic hypersensitivity pneumonitis, and idiopathic pleuropulmonary fibroelastosis. We will talk about IPPFE at the end as it is rare. We will spend most of our time talking about UIP, which may be idiopathic, in which case it is called idiopathic pulmonary fibrosis, or maybe secondary to other conditions. And we'll talk about idiopathic and secondary forms of NSIP. We'll also talk about chronic HP. This is the standard diagram flow chart for defining the diagnosis of UIP. Based on a statement from the American Thoracic Society and other groups published in 2011. If you have a patient with suspected IPF, if there are identifiable causes for interstitial lung disease, then clearly it's not idiopathic pulmonary fibrosis. All other cases go to get a high-resolution chest CT, and from the high-resolution chest CT, we produce 3 different outcomes. You can have UIP, possible UIP, or inconsistent with UIP. So it's important to use this terminology when you are reporting these cases. If you make a diagnosis of UIP, then the patient receives the diagnosis of idiopathic pulmonary fibrosis. So this re-emphasizes the importance of knowing the features of this entity. If we say possible UIP or inconsistent with UIP, then in many cases the patient will need to undergo surgical lung biopsy, if clinically appropriate, and then a multidisciplinary diagnosis to decide whether or not they have idiopathic pulmonary fibrosis. The pathology of UIP is characterized by marked fibrosis and architectural distortion, often honeycombing, and often in this characteristic subpleural or paraseptal distribution. Fibroblastic foci are a salient feature, these foci of young connective tissue. The involvement is often patchy, and there are no features to suggest an alternate diagnosis. These are the typical radiologic findings of UIP. It is always subpleural predominant and almost always basal predominant. The salient feature is usually reticular abnormality, and honeycombing may be present with or without traction bronchiectasis. And there is an absence of features inconsistent with the UIP pattern, which we will discuss in a later slide. Here are the coronal images on the same case, and coronal images are very helpful. First of all, it's commonly easier to identify honeycombing on the coronal image, and secondly, you can see the craniocaudal gradient with the disease much more prominent in the lower lungs. Now, here are the criteria for what we call possible UIP. Like the definite UIPs, it is subpleural and basal predominant with reticular abnormality. Notably absent is the presence of honeycombing. That's the only difference between the possible UIP pattern and the UIP pattern. So honeycombing, as you will see and as we will discuss, is important for making this distinction. Again, notice the craniocaudal gradient of abnormality in this case. Now, these are the features that will make you say that this patient is likely not to have UIP or inconsistent with UIP. If there is upper or mid-lung predominance, if there is peribronchovascular predominance, if there is extensive ground glass abnormality greater than reticular, if there are profuse micronodules, discrete cysts, diffuse mosaic attenuation, or consolidation. This patient, as you can see, has mosaic attenuation, which usually makes the patient inconsistent with UIP. We'll talk about this in a little greater detail in a few minutes. Now, here is the reason why we as radiologists are permitted to make the diagnosis of UIP. These are multiple studies going back over 20 years that show the correctness, the positive predictive value of a confident first choice diagnosis of UIP made by an experienced radiologist. You can see that in almost all cases it is over 90%, which is really remarkable for a non-invasive test. However, you will notice that there is a substantial proportion of cases in which you are not able to make such a confident CT diagnosis. So you cannot expect to get every case right, but if you have a typical CT finding, set of CT findings, you will usually be correct. So honeycombing, as we said, is the pivotal diagnostic feature of UIP. It's present in probably 50 to 80% of cases of UIP. It remains the strongest indicator of UIP on CT, and it does appear to have at least some survival implications in terms of predicting median survival. Now, the definition of honeycombing we have to be careful of. It is defined as clustered cysts or a row of subpleural cysts that are usually less than 5 millimeters in diameter. Sometimes you have a single row, as in these two cases. Sometimes you have multiple layers of cysts. There has been this paper published a few years ago looking at observer variability in assessment of honeycombing, which essentially showed that there was only moderate agreement in diagnosis of honeycombing. However, this paper, first of all, used only single CT images, and secondly, included substantial numbers of cases with atypical honeycombing and non-honeycomb cystic spaces. Here's an example of a patient with quite extensive traction bronchiectasis, and you can legitimately disagree over whether these subpleural cysts represent true honeycombing or represent traction bronchiectasis. Often on coronal imaging, or on serial axial images, you would be able to sort this out. Here's a patient with unusual cysts that are not subpleural and relatively large. We often see this sort of finding in cigarette smokers. Very difficult in some cases to distinguish from true honeycombing. Now, what about this category of possible UIP? Well, it turns out that there are some subsets of this. We can identify people that look like UIP, basal predominant, peripheral predominant reticular abnormality, just no honeycombing, and we can call these probable UIP. And in contrast, we have other cases where it's really much less specific. Patchy ground glass, maybe there's basal predominant, and these need to be regarded as indeterminate. It turns out that if you look at the probable cases, if you look at the indeterminate cases, only about 50% of them turned out to have histologic UIP, but in the probable cases, 80% of those subjects had UIP. One important point for you to be aware of is that the probability of IPF as a diagnosis increases dramatically with age. If you are reading a scan in a patient that's less than 50, you should be cautious about making this diagnosis. But if you have a patient that's over 70, the pretest probability of UIP is very high in that context. Another important thing for you to be aware of is that you may have atypical appearances with UIP. We had, in this study from a few years ago, there were 55 subjects with biopsy-proven UIP, and only 20 had a high probability CT diagnosis of UIP. Now that's not surprising because people with a high probability diagnosis of UIP shouldn't actually be getting biopsies. But what we have to be comfortable with is that some people with atypical appearances that look like NSIP or chronic HP may in fact turn out to have histologic UIP. And here's a study that we recently published that shows basically the same thing. These were patients who were all enrolled in clinical trials for IPF, and we reviewed all these scans centrally and found that about 40% of them had features that seemed to be atypical for UIP. Notice that in this very selected population, 94% of those subjects had histologic UIP. So what does this mean? It means that the term inconsistent with UIP is probably no longer accurate, and we need to come up with a better term, probably indeterminate rather than inconsistent. Here is such an example, diffuse ground glass abnormality. I would never have called this UIP, but UIP was the confident pathologic diagnosis. Here's a patient with mosaic attenuation, expiratory air trapping, and again, confident histologic diagnosis of UIP. When we have a patient with UIP and we look at serial images, we find progression over time. Areas of reticular abnormality progress to honeycombing, and there is increasing extent of reticular abnormality. Here's a patient with UIP, confidently diagnosed, baseline, comes in short of breath 5 months later, gets, as you would expect, a PECT that shows diffuse ground glass abnormality superimposed on the background fibrotic change. What do you think of in this case? Well, this is an entity that's called accelerated deterioration or acute exacerbation of IPF. Important to be aware of because the radiologist has a primary role in making this condition a diagnosis. It accounts for a substantial proportion of IPF-related deaths. It may occur in other interstitial pneumonias characterized by acute progression of dyspnea over 1 month or less, with new diffuse ground glass abnormality on chest X-ray or CT. The other important complication for you to be aware of is lung cancer. Lung cancer happens with increased prevalence in patients with UIP, and you can see that it often begins in the area of fibrosis and may be difficult to distinguish from background lung fibrosis. Always be suspicious of nodules, particularly if they're new, occurring in patients with UIP, and get an early follow-up scan. We do find also that PET-CT is very useful if we're concerned about a nodule in a fibrotic patient. The prevalence of lung cancer ranges from 5 to 15%. It's often peripheral and lower lobe, and it may be multifocal, but it may be resectable and lead to long-term survival. So again, the radiologist has a critical role in making this diagnosis. Briefly, we need to say that UIP is not always idiopathic. It can be seen in collagen vascular diseases, particularly rheumatoid arthritis, and may be seen in hypersensitivity pneumonitis. Now we're going to move on to NSIP. If you look at the textbooks or the articles that have been published on the CT appearances of NSIP, you're going to be confused because there's a wide variety of appearances. But this, if you look at this image on the right side of your screen, this is the typical appearance of NSIP. Like UIP, it is basal predominant. Unlike UIP, it tends to be peribronchovascular and often with a zone of subpleural sparing. It is often more confluent than UIP. There's often bilateral lower lobe volume loss, as you can see in this case with posterior displacement of the fissures. Often there's a component of ground glass abnormality along with the reticular abnormality and traction bronchiectasis. Consolidation may or may not be present, and honeycombing, if present, is rare. So that's very different from the typical appearance of UIP. Here are some more examples. Notice the peribronchovascular extension of this fibrosis, marked lower lobe volume loss, and traction bronchiectasis. In this case, again, note the marked traction bronchiectasis and subpleural sparing. Now, importantly, there are other entities that mimic the radiologic pattern of NSIP, and they include UIP, as I showed you in that previous case, also LIP, smoking-related diseases, and hypersensitivity pneumonitis. So that's why we are usually much more reluctant to make a confident CT diagnosis of NSIP. Importantly, if you see a pattern that looks like NSIP, it's highly likely to have some underlying condition, either collagen vascular disease, environmental exposure, drug toxicity, or what's called undifferentiated connective tissue disease. Here's a patient with scleroderma with typical appearances of NSIP. Here's a patient with hypersensitivity pneumonitis. Notice the mosaic attenuation suggestive of HP. Here's a patient with asbestosis. Notice the calcified pleural plaque. And here's a patient with drug toxicity due to nitrofurantoin in a patient with NSIP. So there's a longer differential for an NSIP pattern than a UIP pattern. Now, NSIP does have a better prognosis than UIP. Some cases, perhaps about 20%, get at least somewhat better over time, as you see in this case. Most cases, probably 50%, stay exactly the same when you follow them for many years. They just have persistent lung fibrosis without progression or without improvement. A minority of cases progress, and some of those over time progress to a more UIP-looking pattern. Final part of the differential of fibrosing interstitial pneumonia is chronic HP, and that may be upper, mid, or lower lung predominant. There are clues to the diagnosis. You may have centrilobular nodules or mosaic attenuation, but sometimes, as in this case, there is actually no clue to the diagnosis of chronic HP. It looks like it could be NSIP, so you always have to bear that in mind. Here's a patient with a more typical pattern, fibrotic appearance with traction bronchiectasis, but notice the areas of mosaic attenuation. Very important to do expiratory imaging in these cases because it will accentuate the areas of air trapping and identify areas that you didn't know had air trapping. And again, it's important to diagnose chronic HP because the management is different and some of these findings may reverse over time. So this is a review then of the typical appearances of HP, UIP, and NSIP that I find useful. In this series, the prevalence of ground glass and reticulation is about the same. The prevalence of honeycombing is higher in chronic HP and UIP, relatively rare in NSIP. Lobular areas of decreased attenuation, more common in chronic HP, but it also could occur in the other conditions. Centrilobular nodules, more common in chronic HP. Subpleural sparing, as I mentioned, is much more common in NSIP. And lower lung predominance, common in UIP and NSIP, but also present in about 1/3 of cases of chronic HP. Now we're going to move on to the smoking-related lung diseases, and we'll talk about each of those in turn. Respiratory bronchiolitis is the commonest form of smoking-related lung injury, with the accumulation of these dusty brown macrophages within the respiratory bronchioles. On CT, what do we see? We see ground glass abnormality and maybe some we see ground glass abnormality and maybe some centrilobular nodules. Dirty looking lungs and very typical. The first question you ask if you see a pattern like this that's hard to describe is whether the patient is a cigarette smoker. It's often asymptomatic. Some patients with respiratory bronchiolitis who are heavy smokers develop this uncommon condition called respiratory bronchiolitis interstitial lung disease. And in those cases, the ground glass abnormality and centrilobular nodules are usually more extensive. And then DIP is at the far end of the spectrum. That's a more diffuse process with macrophage accumulation within the alveoli and alveolar septal thickening. A clue to this diagnosis is the presence of numerous cysts within the areas of ground glass abnormality. It tends to be lower lung and peripheral predominant. Organizing pneumonia is a more acute. Now we're into the more acute entities. It's usually subacute and presents with consolidation and or ground glass abnormality that may be subpleural or peribronchial. The findings are often nonspecific, but here are two important clues. The first one is the presence of perilobular thickening, that is, irregular thickening of the interlobular septa, which in the correct context can be highly suggestive of organizing pneumonia. And the second one is what's called the reverse halo or ATOL sign, where you have peripheral consolidation and central ground glass abnormality. As with the other interstitial pneumonias, there are several causes of organizing pneumonia, including cryptogenic, collagen vascular disease, particularly polymyositis, dermatomyositis, drug toxicity, and aspiration. Then the most acute entity is acute interstitial pneumonia, presents with acute onset, severe hypoxemia and respiratory failure, and it's basically idiopathic ARDS. And the imaging is typical for ARDS. You get this mixture of ground glass attenuation and consolidation, which is most frequent or most prominent in the dependent lung, often with areas of spared lobules. In the later phase of AIP, you actually do get traction bronchiectasis, which tells you that the patient is in the organizing phase and developing fibrosis. AIP may be due to any cause of ARDS, as I've listed here, or maybe idiopathic. Now we're moving to the rare entities. The most important thing to know about LIP is that it is rarely idiopathic, usually associated with underlying diseases such as Sjogren's, rheumatoid arthritis, pediatric AIDS. And then the most important radiologic clue, in addition to the ground glass abnormality, is the presence of cysts, which are typically perilymphatic, peribronchovascular, or subpleural in location. Here's the rarest entity. It's called idiopathic pleuropulmonary fibroelastosis, IPFNET. On the chest X-ray, it presents with bilateral upper lobe volume loss with dense pleural and subpleural fibrosis, traction bronchiectasis, and volume loss. Here's a CT. In the same case, you see this irregular thickening of the pleura and subpleural fibrosis with volume loss. On a coronal image, you can see the marked architectural distortion in the upper lungs. The final couple of minutes, I'm just going to talk about the importance of a multidisciplinary approach to IIP. So here was a study from Dr. Flaherty from Michigan several years ago now, where they looked at 58 cases with suspected idiopathic interstitial pneumonia. And clinicians and radiologists and pathologists reviewed them independently, followed by multidisciplinary consensus. The important point was the consensus review caused an alteration of 53% of the radiologist's diagnosis. That's okay, because the radiologist did not have any clinical information. And these were cases that had undergone biopsy. 34% of clinician diagnoses were changed, but that's because the clinicians actually had the CT scans as well as the clinical information. Here's the most important point to me is that in 1/5 of the cases, the pathology diagnosis was changed on multidisciplinary review. So this is a condition where the pathology diagnosis may change and almost always based on imaging. Here's another example of this in a workshop of NSIP that I participated in quite a few years ago. They had 104 cases of probable or definite NSIP. And of those, 38, or approximately 1/3, had the diagnosis changed. 21 based on the CT alone, 14 based on CT and clinical, and 3 based on clinical alone. The most common alternative diagnosis, provided usually by CT or by clinical, was hypersensitivity pneumonitis. So in summary, idiopathic interstitial pneumonias should be divided into fibrosing interstitial pneumonias and the non-fibrosing entities. Honeycombing remains the most important discriminator between UIP and non-UIP. Smoking-related lung disease is increasingly recognized and is usually diagnosable by CT. And multidisciplinary diagnosis really does make a difference, and in particular, you should remember that sometimes the radiologist is right. Thank you very much for your attention.